Hello and welcome to the World of Optometry webinar. You are all very welcome wherever you are joining us from today. So my name is Cherise Condenuevo and I will be hosting today's webinar. I am joined by Dr. Rehab, another moderator who will be assisting me in today's presentation. Before we get started, it is important that we cover some general housekeeping. Please have your cameras off and mics off. This is to eliminate any background noise which can cause feedback and noise disturbance to the speaker and other attendees. So don't forget to rename your electronic device as well with the name that you are registered with. So this is the name that you will receive on your certificate of attendance. If your name on the device does not match the name that you are registered for the webinar with, you will not get your certificate of attendance. Another thing, to receive your certificate of attendance, you will be required to stay for the duration of the webinar, after which we will send you a simple review form to fill out via email. Please post your questions into the chat box feature, and you can do this at any time during the presentation. They will be answered at the end by the guest speaker. Please address your questions to everybody option. Dr. Rehab, which is the moderator too, will be able to assist you with any technical difficulties. So if you are experiencing any issues with sound or picture, please let us know in the question chat box. You may contact us to rename your electronic device during the presentation. If you have any queries about getting your certificate of attendance and this process, either I or Dr. Rehab, the other moderator, will answer your queries. So without further ado, today's presentation will be between 35 to 45 minutes, followed by a question and answer session. And I am very delighted to present our guest speaker this evening, who is Dr. Maria Roxanne Bandoja. She's currently practicing as a senior ophthalmic technician at Center for Sight, United Kingdom. She has more than 10 years of experience as clinical optometrist, including specialized contact lens fitting at Maghrebi Eye Hospital, Saudi Arabia, and United Arab Emirates. So the title of our webinar for today will be Physiological Ocular Changes Among Geriatric Population.
So hi everyone, good afternoon, good morning. I don't know which country you are in. So today I'll be talking about structural and physiological ocular changes among their geriatric population. Okay.
I'll share the screen. Okay, this is the first slide for you.
First of all, what does geriatric mean? So it refers to the elderly, it's like a synonyms for old persons. Okay, and then what does geriatric comes from? It's an healthcare system of the elderly. Okay, next slide. I just want to point out that of course we're dealing it every day, like for pedia, geriatric. So this one is geriatric, and then the other term is gerontology, which is the branch of science that deals with the aging process. Next slide. Okay, next. Okay, so process of aging is strongly influenced by the effects of the environment, lifestyle, and systematic diseases that in turn are related to aging, but are not due to aging itself. Next. So I'll show you some images and some description about common aging eye problems. So let's start with the eyelids. Next slide. Okay, and then have you encountered some of your patients with blepharochalasis? So on the next slide, you'll see this a sample. This is the redundancy of the skin of the eyelid. So it's also one cause of disturbance to your full vision. So as you can see from the eyes of the patient, the skin is already blocking most of the whole pupil. Then let's go to entropion. This is one also. The entropion is also a disturbance in the vision, which is this is the inward turning of the eyelid margin. And then there's two types of problem on the eyelashes, which is entropion and ectropion. This is the inward turning, and for the ectropion, this is the outward turning of the eyelid margin, which both of these causes the eyes to have watery eyes for our patients. Then it irritates the anterior segment of the eye due to eyelashes. So try to imagine if you're blinking and then the eyelashes is like a foreign body sensation in your eye. So when a patient comes in and they said to you like I keep having watery eyes, immediately there will be some factor that you will think about, that maybe it's not just dryness, it's because of their eyelashes. Okay, let's go to the, since we're talking about dry eye, the next slide will be about dry eye syndrome. Okay, next slide. Okay, dry eye syndrome is usually caused by ectropion and entropion due to the uneven distribution of tears in the eye. So this one is a best example. Then for the eyelashes, this is a poliosis. Next slide. So this is a condition wherein the eyelashes or the eyebrows changes into a white or grayish color. So this is also some formation or changes in ourselves when we grow older. Even our hair at the top will be changing to this color. It also affected on our eye. So sometimes, next slide, when you grow older, it's either your eyelashes are turning white, grayish, or totally it will be falling out. So this is called madarosis. It's a condition where there is a loss of eyelashes. And it's also very hard if you don't have eyelashes, because it's also the protection of our eye from our oily sebaceous gland. Now let's go to the cornea. So for the cornea, if your patient is having some pigmentation, some color on the eye, we don't think that it's immediately like cataract, because that's the mostly known disease, or mostly on the common or layman's term. They always think that they're having this cataract. So for us as an optometrist, we're trying to find out if they are just having arcosinilis. So here are some slides for you to check. So if the eyes are gray, the arcosinilis is not when you try to look it on the slit lamp, it's not immediately it's full like that, and it's also an indication of the patients having some cholesterol, fatty deposits on their eye. So we can tell on that. So as you can see on the slide, the grayish white arc formation on the limbal area, that is due to fatty deposits. So from this one, now the crystalline lens will be affected. So next slide, please. So this is an example of an old man who's having a lot of circosinilis, but of course, it's not cataract. So let's go to the crystalline lens. So I know everyone can determine if a patient is having some crystalline lens. I know that everyone can determine by going to the crystalline lens if the patient is having cataract. So this is a sample of how a mature cataract will be looking. So during next slide. So presbyopia. As we grow old, in prescribing glasses at around 40, we think that reading glasses will be applicable for them. It's called the presbyopia. So on this, lens become hardened as we age. That causes the crystalline lens to become less elastic and flexible. It weakens the ability of the crystalline lens to change its shape for accommodation. So this comes for us to refract the patient and start to give reading glasses. So what is the most important of knowing the structural, physiological, ocular changes among the geriatric population? So a patient comes in, it's better for us to know that it's only because of aging that the one that I presented on you is a part of their formation. It's part of their changes as we grow older. It's not we are giving assurance to our patients that these are just phases of each person's um aging process. So it's not a disease, it's not their self-esteem. Usually I have one patient before that when they have arcosinilis, they have this self-esteem. They said that they are being bothered how the white is turning how that white is making their eyes cosmetically. So as an optom or as an healthcare practitioner, we should be explaining how this changes in their self, how they can adapt on this, and it's totally normal for them to have this one. So next slide, please. One of the World Health Organization plans for addressing the needs of the geriatric population is ensuring healthy aging for all. It is clear that early actions yields the greatest benefits, both better health outcome and generally improve quality of life and productivity. The earlier we prepare, the better. It's like also prevention is better than cure. Am I correct with that?
Of
And
course,
then,
absolutely.
yeah. So first of all, I believe that we are all accountable for everyone around us. We as an individual should ensure on our future and stop the stigma of giving all the responsibility to the younger generation. We should be responsible for our own future. Like when you're growing old, especially this pandemic, everyone now tends to be more healthy. So as part of yourself, if you really love yourself, I mean, why not start to be conscious of taking care of it and not wait when you reach 40 or 40 or 50 that you tend to have this healthier lifestyle? Why not start now? So our future sons and daughters are not our insurance. We should not burden them. Instead, we must establish a future for them while ensuring our own future as well. As early as possible, we must be minded of our own health. We should not risk our health because when we become diabetic or hypertensive, because of the unhealthy lifestyle that we are doing right now, we lived when we were young, our future will not just be burdened on taking care of such, that they will have a hard time to pay for our maintenance. And also for us, because the maintenance costs a lot for having hypertension, diabetic, like for dialysis, you know what I mean. So growing old is inevitable, but that gives us the advantage of knowing what we could prepare and then we are already there. So for me, being old is also gold because as you grow older, it's like wine. The more older you are, the more expensive you are. So thank you for listening. It's really my first time, so sorry.
No,
I'm
that's okay.
stuttering.
Absolutely. We picked up some good points from you. Especially, you are right. You mentioned about the fact that people most often confuse cataract with varicocele. So that's very true. And us, optometrists and educators, we should really inform our patients with regards to this, and also the public, that there is a difference. The good thing about that is both is manageable.
Yeah. And then, of course, I know some of you might be wondering why I did not put the, why I did not put about anything regarding with the retina and then for the macula. It's just that I'm just showing and focusing first on the structural. But we once a patient comes inside, of course, what we do is an assessment. So
Mhm.
I'm just focusing first on what you will think when a patient comes. So at least one by one, probably will give this opportunity to another person on elaborating the retina and the macula, because that's also part of our geriatric. And you
Yeah.
know that retina has 10 layers. It will take time for us
Yes.
to explain it more elaborate, more accurately with that. So to elaborate all of the diseases that the retina can affect. So this one, I just want you to at least for me and for you to be enlightened on how we can assess a patient when they comes in. And as much as I know everyone is well informed here, that's why I just made some pictures for us to at least see the actual images when a person comes into you or had this consultation. That's, I know everyone here is more aware on me on that, and I don't need to discuss on bullet type on this. So that's why I'm sorry for the slide. I just make it short because I know too
Yes.
much as me is a little bit boring. At least we're concentrating on the eye itself and the images that we can relate more.
That's absolutely right. I believe that there's a lot of topics to be covered under this topic, this geriatrics. So there's more, and I don't think that time for question and answer portions. So I now hand you over to my colleague, Dr. Rehab, for the question and answer session. Okay,
Thank you, Dr. Cherise.
thank you.
So we have some questions which have been submitted by our attendees, which I will read for you now. Can you please share So question 1. At what age would you become suspicious that varicocele may be due to high cholesterol rather than ensign or aging?
At what age would you become suspicious? That, according to my experience, it's around 50 years old. Okay, and then usually on the clinic practice, what we do is that we ask the patient for a cholesterol check, and then during the assessment, upon interviewing or asking your patient for concern, you'll see the list of the medications that they're having, and some medications are also one factor or having that
Contribution.
I think there's one medicine that for migraine, it's Topamax. It's also a side effect for arcosinilis. So upon getting all the medications of a patient, we can be also having an idea of how high cholesterol, and then ruling out if it's due of aging or because of it's due of other factors, lifestyle factor of the patient. But for the practice that I have been encountering, it's usually 50 years old.
Yes, I
Okay,
believe that's very important, clinical diagnosis. So yeah, let's move on
yes.
to the next question.
Yes, next question. So what is one ocular lubricant that can be used to manage both causes of dry eye effectively?
On the market now, as you can see, there's two types of dry eye that I have read through. It's evaporative and aqueous deficiency. So if you will just use one drop, it will not help. So usually it's two medication that we're giving for most of the patient. Like if the patient has a meibomian dysfunction or evaporative dry eye, what I can see on the doctor is that what they're prescribing is always Artelac Advance. That's for evaporative dry eye. But if it's the aqueous deficiency, or we call it, I think, DED sometimes, that's a lacrimal gland problem, they give it Hylogel, Cysteine Ultra. So for me, on my opinion, there's no one. It's always like two medication, and we need to find out if that what type of dryness is the main root of that patient before we can say if one is good enough. I think for the stage 1 of dry eye, we can have one lubricant for that patient.
Okay, great. So let's move to the question number 3. In Europe, where there is very little UVC, sunglasses just offer UVA and UVB protection. Are there differences elsewhere where there are high levels of UVC?
First of all, I think UV wavelengths vary in size and differ in how they affect our skin and our eyes. UVC is the shortest and not long enough to reach our skin. This type of radiation is filtered out by the ozone layer so that none reaches the Earth's surface itself. Then ultraviolet C, I think, is germicidal and is also used in ultraviolet phototherapy. It doesn't really have any severe effect on us, whether you live in Europe or someplace where there are levels of UVC.
Thank you very much for answering those questions. Unfortunately, in the interest of the time, we may not have answered all the questions. If you do have any further questions you would like to be answered, you can email them directly with the email address which is on the screen at the moment, and I'm sure the speaker will get back soon, quickly as they can. I will now hand you back over to Dr. Cheris.
Thank you, everyone, for your attendance today. Thank you, Dr. Rehab. Thank you, Dr. Roxanne, for your contribution to us. It's been a very fruitful webinar for us. We picked up a lot of good points from you, and it's a refresher also for us. Your thoughts are very important to us, and we will be sending you an email for you to fill in and submit the short feedback survey to complete the requirements for your certificate and to guide us in our future presentation topics. So the next World of Optometry webinar, we will announce it soon, and please just watch out for our social media posts, and we will update you soonest. I will now bring today's presentation to a close and wish you all a very good day. Thank you, guys.